Welcome to the AT Pit Crew podcast. This high-energy show dives deep into the world of sports emergency care. Join us as we explore cutting-edge strategies, real-world experiences, and expert insights to help you step up your game in emergency care. We've got the tools, tips, and stories you need to be ready when seconds matter. It's time for the AT Pit Crew podcast. We have the green light in 3, 2, 1.
Welcome to the AT Pit Crew podcast. I am Ryan Hart, your host for today's episode. If we haven't met, I am the sports medicine event manager with Action Medicine Consultants, and I'm excited to be here in the host seat for today's episode for the very first time. With me, today's guest is Dr. Ray Castle, a leader in sports emergency care and athletic training. Today, we're diving into a skill every sideline clinician should master, and that's taking blood pressure by palpation. And more importantly, why recognizing systolic blood pressure in emergency situations can make a major difference. So here we go. Let's get started.
Good deal. Good to be here. And Ryan, thanks again for having you on as being the host now. So it's kind of nice to be in the not be in the driver's seat every now and then. It's kind of it's fun just to be on the ride, so to speak. So as we take 10 laps today on really, I think, a really interesting topic that's kind of overlooked in emergency medicine.
Absolutely, Ray. So like you mentioned, we're going to be going through 10 laps with you today. So let's dive in with a few questions on those 10 laps. So here we go. Setting the stage. Let's talk about blood pressure being a key vital sign, but often athletic trainers, I find, rely on other methods. So, Ray, can you talk to our listeners just a little bit about setting the stage for taking blood pressure by palpation?
Yeah, so it's one of the things that it's that I've seen a lot in our pit crew course and other courses we do over the last year or two. It's just thinking about how we need to collect vital signs. Often, we're in a very loud environment. And it is, I like to use this approach, using a data point. It's really critical. One's better than none. Two is better than one, kind of so on and so forth. When we're collecting data, especially when we have to get that handoff to EMS. And this is it's a valuable data set. It's not incomplete. It is incomplete. In fact, you want to have a systolic and diastolic, but if you don't have it, you can still get that, especially in a loud environment. So that's kind of really what the focus gets into, is just providing, it helps to paint the picture, so to speak, when we are look at the patient status and then where we are just giving that patient on based on the situation.
Absolutely, Ray. And you talked about being in a loud environment. Emergencies rarely give us perfect conditions for an assessment of vital signs like blood pressure. Can you talk to our listeners maybe about some of the most common scenarios where palpation would be the best option for obtaining a valid blood pressure?
Well, I think you think about the sports settings, like, for example, a football game, or in a gym where the band is going, or it's loud. You've got music playing. It's hard enough to you can hear that all, get a good sound. So when you're thinking about that, if it's difficult to hear, period, like even some of the events we cover, like the endurance events, like marathons, they've got music playing and the band's not going to stop. If you're on the sideline trying to do a blood pressure or other things as well, or in a court, it still keeps going. So you have to be able to find, just to get the data points you can achieve. It just still gives you, even though it's not complete, it does, and you're not able to go into a quiet environment, then at least you have something to look for. You have an idea to look at least some type of valuable and accurate measurement that you can bring along or package in with your initial core vital sign set to determine, get a baseline vitals, and then you can work at trending, especially if the patient is deteriorating.
Yeah, that's some great information. Hopefully it's getting our listeners kind of thinking a little bit about their own practices, games, scenarios, things that they're covering. So let's break down the skill a little bit better for practitioners who, either haven't practiced the skill in a while, or maybe they've never even heard of this. Can you walk our listeners through kind of a step-by-step process of taking blood pressure by palpation in a sports emergency situation?
Well, I think just go back and look at, you look at a blood pressure assessment in general. So you obviously have a cuff, you have the right size, the right size cuff for the arm, or let's say the patient. You have your stethoscope on and you put your measurement star, you start pumping it up. So again, when you're looking for the disappearance or the occurrence and reoccurrence of the sounds, which are the court cough sounds for blood pressure, when you hear 'em moving through. So, or it disappears. So all you're doing, you pump the cuff up, you may go to 180, et cetera, and you start backing it down. So when you first start hearing that pulse, that sound, that's not looking at the gauge, but you're listening to that sound and you recognize when that sound occurs. That's the first sounds for systolic. It's court cough sounds. And then when it dissipates, you move it down to like 80 or 70. That's when it disappears. That's the diastolic sound. The only difference is that now you're just combining two skills into one. You're going to find a radial pulse. You can also do this on a brachial pulse. If the cuff is high enough, you could do on the brachial side. It may be very seldom you may do that. But again, you're getting a radial pulse, you identify the pulse, and then, you do this with one hand, and the other hand, you're pumping the cuff up and controlling the cuff. So you pump them up, and then when you move it back down, and then when you first feel it, it's going to occlude the arterial flow. So when it restarts back again, you note it on the cuff and you record that measurement. And that's all it is to it. It's really easy. You're just recording systolic and you say, I've got 160 over pulse, pressure over palp or by palp. And it's understandable what that is.
Excellent. Well said. You talked about in the beginning of that explanation, you talked about the right size cuff, and equipment can make all the difference. Why don't you talk to our listeners a little bit about what equipment they should have in their kits to successfully perform blood pressure by palpation, and maybe what are some of any of the gear related pitfalls to kind of watch out for or be cognizant of?
Well, I think, when our kits, we have them set up, and I think just a vital signs kit. That's not, you can do that if you have electrical, like an electronic cuff, you could do by wrist. That's the offshoot of that. You wouldn't need to do that if you have an electronic cuff. And now they have that, put it on the wrist cuff or on the arm. Those will read those. You'll get the vitals from that. But again, if the battery doesn't break, it's just more mechanical. So in our kits, we have a pen light, and it's one like a BP cuff set is contained. We put pulse oximeter, which you can do pulse rate and oximetry, or if you get some better ones, bigger cuffs, you can get mean arterial pressure. But we're really looking, for this really rapid in the pen light and a glucometer. So those are all in one. So if I pull one out, if I pull that bag out just to do blood pressure, I know I need to get those other vital signs. It's just more of an easy reminder, and you don't have to go scrounging around trying to find something as well. So that's really the main thing, is having a cuff, whether it's digital or it's a manual, you're able to perform that, get that measurement.
Yeah, absolutely. I like what you said about having all of your vital sign equipment in one bag. I had the same thing back in Atlanta. We kind of referred to it as the vital sign go bag. And because mistakes can happen when you're under stress, let's maybe help our listeners kind of avoid some of these mistakes. What are the most common errors you see when clinicians are trying to do palpation or blood pressure by palpation, and maybe what are some tips that you would give to help our listeners get this skill correct?
Well, I think the one thing early on, you see blood pressure and you'll see it on a gauge, and it's starting to, that jumping, right? When it gets closer, you start seeing that, and confusing that for getting a measurement versus what you hear. You have to be able to hear it. It's not a visual. The only time it's going to be visual is if you're actually, you're recording it, but it's not a visual. This is not a visual technique. If you're recording digital, it is visual, but it is a physical assessment. And that's a really key difference, is not to look at that measurement. You can start to see if you're trying to control the measurement, if you're moving too fast on releasing the pressure. But again, it just has to go into, you're able to see where they're going to start. You may start seeing to jump some where you're getting closer in pressure, but until you actually palpate it, or in the case if you have the stethoscope and do auscultation, then you're actually recording the initial actual listening or the palpation technique. The other one is just, I think, just understanding what it measures. How the question gets into how accurate it is. Well, it's usually within 4 to 6 millimeters of mercury compared to auscultations. Again, you're not getting diastolic. So you're thinking, okay, typical is 120/80. You get this pressure and it's below 90. You get into 80. They're going to be showing up as a rapidly deteriorating patient if they've not already decompensating or potentially. So again, that has to be thinking of where that may be in a normal pressure. 90/60 is not necessarily uncommon in like an elite person or someone who's typically generally at rest. I'm not going to say hypotensive, but they have a lower blood pressure values than you may see a 120/80 or et cetera. So just to make sure you're not underestimating that using that tool, but also understand that palpation may underestimate in some cases, such as shock and weak pulses, the measurement you get. So you just got to be aware of that and looking at the person as a whole in terms of that vital sign assessment.
Yeah, I really like that. And you actually kind of already started touching on some of the questions that I wanted to ask you next. Getting more into like the details of what this technique is actually giving you in terms of a vital sign and how that correlates to guidance within that emergency situation. Are there any additional details you maybe could give our listeners regarding specifically what you're measuring, the systolic blood pressure, and how that correlates to providing care during that emergency?
Yeah, I think the one I did not mention is, I'm glad you asked that question, is when you think about kind of a rule of palpation or pulse palpation or its rules. So if you're doing and this is in the field estimates, it's not going to be set number at zero, but if you're doing a carotid pulse palpable, if it's palpable to what level it is, you're thinking about 60 millimeters of mercury. If you go to femoral, you got to think systolic's going to be at least 70 if you're doing a femoral artery, if you're palpating. I'm sorry, the systolic BP. And radial is going to be, if you're palpating it, radial is going to be about 80. So just think about the systolic pressure of what that normal values are. And these are, again, it vary. That's going to vary. You can't say, oh, it's because it's 60, 70, 80, this is locked in. You have to be thinking about what the patient's presenting as. Also, take into consideration, you've got noisy environments, if that's a problem. You have a person who has low perfusion rates. If they are already having labored breathing, or they have some type of, breathing versus internal bleeding, like for example, a femoral fracture, those perfusion rates are going to be really low, or you have the stethoscope's not available, or in the case it breaks or the end comes off by chance. So again, it gives a quick affirmation of one data set, gives a quick estimate to see where they are in that. And it's used more as a pivot. You're going to try to do blood pressure by auscultation. And if you can't get it like by 2 times, and just go right to the palpation, get one measurement and then move on.
Yeah, something is better than nothing, right? And so now that we've obtained our blood pressure, kind of talk to our listeners about how do we effectively communicate our readings to EMS or to physicians during a fast-moving emergency situation?
Well, I think you go back in, and I don't want to go through a lot of detail on a MIST report, which it's a handoff format. It's very concise. It's very to the point what you're doing. You want to be able to give, these are what the vital signs are initially, the set. In that case, you're going to say, oh, respirations are 20, initial assessment respirations 20, pulse ox was 93, BP over PAL was 7 or 80, or get something, whatever number, just making something up, and so on and so forth. Cool, clammy skin, etc. This is what we did. This is the intervention you did. Whether it could be putting a mylar sheet to keep them warm. It means if you administered medicine, rescue medicine, for example, if you're giving a, let's say, for example, an anaphylaxis, do the EpiPen administration. Well, a couple minutes, you need to know what the initial value is, but then 5 minutes later, just know that you're going to have a change in with epinephrine. You're going to see a rise in or an elevation in vitals. So just got to be aware of that, and then they may roll back down again after several minutes. So just knowing what that looks like, that's the biggest thing to communicate. Practice it, be with confidence. It takes some time if you don't do that, and then be able to give that back very simply if you're passing it on to EMS so they know what that looks like. So again, you're just handing them off and they're having to move forward, but the information needs to be very simple, concise, to the point. Hey, is there any other information you need? And that's simply just good. Not time when, either the provider coming on the unit, whether it's, EMT or medic, they're coming in, they're going to they may ask that question, they may not, but it's always good to, hey, what other information do you need? And then they can help just in case you miss something, it helps them fill in the gaps.
Yeah, that's some really great nuggets for our listeners, to kind of hopefully think on a little bit and, eventually practice and implement into their clinical skills. And speaking of practice, let's kind of shift gears a little bit and start talking kind of in that direction of how do we start preparing for this? How do we implement this into our protocols? Talk to our listeners a little bit about maybe how athletic trainers should include blood pressure by palpation in their emergency action plans, in their practice drills, and incorporate that into their.
Well, I think the easy thing is you have it part of your skill set of your training. I mean, if you've done it, it's not something that, I get to ask, well, how often should you practice these skills? Well, skills can erode pretty fast, and either from compressions, CPR, it's well documented, some other skills as well. I think if you do it and you're doing enough, it's just pretty easy to get, to do that. I think in terms of just general skills that would be practiced, what the question gets into more so is what skills are you applying into emergency situation based on its per protocol. So you're just having to practice that in the real time. I think something easy to do is you can do these in 3-minute scenarios you present in a staff training. It doesn't take a lot to do that, where you're just trying to get them initially here, 3 to 4 minutes. You run through a scenario, you're going to have to do the first things first, do the initial assessment, find the problem, start treating the problem. If it's spine, you have to think of issues related to that, or circulation, airway, breathing. You're just identifying that. You're not doing about this on the front side. You're not checking you need to do is the airway clear? Is cool, clammy skin? You're recognizing there's a problem, try pushing interventions, and then, as part of some of your secondary assessment, or immediately after doing an intervention, you've got to get those vitals and then work on trending set every 5 minutes. Unless they're stable, then you can do it every 10 minutes.
That's some excellent news for our listeners.
It's easiest to practice this. I mean, it's a one-off, but you have to practice. You need to know that, hey, just put loud sounds and just practice it once or twice. You can kind of see the difference of, well, this is really easy to do. But use it it's not the measurement, it's the pivot. If you're not able to get by auscultation, that's the main thing to think about. Is it's not the go-to measurement. It's just I have a plan A, which is by auscultation using digital or by manual blood pressure. And if it doesn't work, then go to plan B, which is I can try it by palpation. And then plan C is you don't have that available, or the device or your equipment's broken, which is not good.
Yeah, you talked about you just have to practice it. Let's talk with our listeners a little bit about diving deeper into what that means. What's your advice for athletic trainers out there looking to practice and maintain specifically confidence in blood pressure by palpation, that skill throughout the year, and maybe how often should they be practicing this skill?
Well, I think it's a simple skill. I mean, it's not, we know how to take by palpation or radial pulse, you just check those. You can do it on yourself. You're doing a blood pressure, not on the palpation, for by pulse you can, or anyone else, or if you're getting a pedal pulse, a dorsal pedal pulse, just looking at where you practice that. I think once you've done that, you've done it. You just got to go back and really where problems exist, not necessarily with palpation per se, But if you run through a short scenario, the problem you have to look, if you're doing your evaluation, your drills, the problem is going to show up when it's in real time. Did you forget to do something? Did you do something out of order? Did you do some other things? And this is where skill breakdown, again, you have to know the skill. Once you've done it, then some skills are just, you have to practice. They're more complex, but practicing, know you have those skills, a level of mastery, because if you don't even practice it, you're not going to get confidence in doing it, period. But doing that, and then you move into a skill per protocol, and then you work into scenario, and then the big interdisciplinary, that's the highest one from a, interprofessional integration, where you're moving through this in a scenario, doing very deliberate. Well, they have this and do this, and you just got to move them. You got to move through that progression to make sure that that's going to work at different levels. And then as you do each one, then it starts to speed up. And as you get more confident, it becomes more automatic. And then you can do those things in a very systematic way.
Absolutely. And at the end of the day, there's no better teacher than just personal experience, hands-on experience with anything that you're doing in the clinical setting. Maybe share with our listeners an example where blood pressure palpation has directly impacted a sideline outcome or a change in your clinical decision making from your personal experience.
Yeah, I mean, one of the most recent ones, we actually had there was an event earlier in the year where we had a athlete that had a seizure right near the medical tent. And so, EMS is there. We're not able to get a good pressure. So we're going, we're having to move really fast to moving rapid interventions, having airway collapse, the more of a respiratory, I say collapses, and they're going into respiratory failure. And we had to get vital signs really quick, and trying to get that. And it's loud. We're next to music inside a medical tent. Really can't hear the sounds very well. So we had to do that really quick. And then also getting other vital signs by the time they got the life pack unit, they got it hooked up. They're able to start doing some rapid measurement digitally. But again, you're just trying to move in a very systematic way to determine whatever vitals we can until that other advanced support was able to arrive and other interventions are on site.
Yeah, that's some excellent information for our listeners, Ray. Thank you so much for taking us through our 10 laps. We're going to take a short break, and when we return, Ray's going to tackle our final lap, the rapid fire questions, and then head into that victory lane for one last key takeaway. So don't go anywhere, listeners. I am Ryan Hart, and you are listening to the AT Pit Crew podcast.
Yeah. So when we go back and do this again, Ryan, we would probably we probably put it between number 5, like after number 5.
Yeah.
Not thinking about that.
That's what I was just sitting here realizing.
Okay. Yeah. That's okay.
I was like sitting here looking, I was like,
on this one, we'll take it off. We'll probably just take it off this one time. So we'll do that as well. Or
so
we can go back in
to
yeah. So what we could do is let's record it to see what it sounds like. Hey, we've finished number 5. We're 5 laps in, and we're now going to get into when we come back, we're going to talk about what are we measuring, communicating, just a couple of things. Just do that, and then do that one. Okay.
Yeah. So we'll do a re-record of the break real quick. Here we go. Awesome, Ray. So we are 5 laps into our 10 laps, and we're going to take a real quick break. But when we come back, we're going to continue with lap number 6 and really start talking about measuring and getting into some applications of this skill, and then how we should be practicing it, incorporating it into our policies. So when we return, Ray is going to tackle our final laps, like I mentioned, and then we'll get into maybe our victory lane laps and put a bow on it with maybe a rapid fire question or two for some last key takeaways. So don't go anywhere, listeners. I am Ryan Hart, and you are listening to the AT Pit Crew podcast. Welcome back to the AT Pit Crew podcast. Again, I am your host, Ryan, and with me today is our guest, Ray. So we are moving into our final lap. I've got a few rapid fire questions for Ray, so let's see how he handles these. Ray, tell our listeners, what is your favorite sideline snack to carry with you in your kit? I'm just curious.
Wow. First, it's a lot easier to ask these questions than to get these. I didn't know what you were going to ask. So I'm getting a dose of my own medicine, so to speak. Favorite, I don't know. I mean, obviously having like a Diet Coke periodic, especially if it's a longer event, doing there. And gosh, dog, um, I need something that's really easy to snack on. It could be either like a mixed nuts or even like just kind of some type of, energy bar. The one that I really like, those new packs, like a Fig Bar. Those are really, they come to a pack that really packs a lot of energy, but it's relatively clean, so that's probably my go-to thing. If I'm traveling, that's a whole other thing. I'd probably go with, I haven't had this in a while, and now you mention it, I'd have to go with having an old, not the regular Coke. I mean, you don't want to use regular Coke but having a bottle of Coke, say Diet Coke, that you find in an actual glass bottle, like I grew up, and you pour peanuts in it. So it's kind of one of those things I knew you would appreciate that. Grew up. I know you probably had that in Yazoo City growing up in Monroe.
Yeah.
It's I do it every once in a blue moon. Just, don't do it all the time, but something like that. So,
Yeah,
that's for
that's
for
awesome.
driving. That's a driving long road trips, So
Yeah, a good road-worthy snack for those distant, team trips where you're having to go. Now here's a follow-up question to that though.
Yeah.
What is a snack that you regret carrying in your kit? One that's maybe just absolutely made a mess, left you hanging, temperature change, who knows? I don't know. I'm gonna throw that to you.
Wow. Well, anything involving chocolate. So I don't want it's mushy. It's, if there's chocolate involved, it's just kind of you don't have that, like the energy bars, they make them with chocolate and whatever else. I just don't carry those, period. It's just kind of it's a train wreck. And then also you just have peppermint. So the hard peppermint, not that soft, big ball peppermint junk. Starlight mints.
I'm with you. The hard peppermints.
Yeah.
Awesome, Ray. Well, thank you so much for sharing your insights today. Before we wrap up, what's one thing that you maybe want to let every athletic trainer listening to today's podcast remember about using systolic blood pressure by palpation in sports emergency care?
I just think the simple thing is just understanding what the value of getting a data set. It's information that you can pass along. It may or may not change, but at least it is a data set. It helps to paint the picture. And especially if you had limited resources, just like if you don't have it, if you don't have a BP cuff period, you still take pulse, respiration, skin color, their mental status using AFPU, or if you're using Glasgow Coma Scale, either one. Any of those things helps in just any data helps to pass that along to determine where they were, what intervention you did, how they changed from the intervention, and then moving on, and then you hand those off.
Awesome. Thank you so much, Ray, for being here today.
Great.
And thank you for our listeners for attending today's episode with the AT Pit Crew podcast. For our listeners, make sure you follow us on your favorite podcast app so that you never miss a lap. And remember, it's totally free. I've been your host, Ryan Hart, on today's podcast episode. You've been listening to the AT Pit Crew podcast, and we are out of here.
Thank you for joining us on the AT Pit Crew podcast. We encourage you to like, subscribe, and join our community. For more information about this podcast show, visit www.actionmed.co/podcast. This show is a production of Action Medicine Consultants, LLC. The medical information provided within this program reflects the opinions of the hosts and guests and is intended for informational and educational purposes only. It should not be considered as a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your healthcare provider with any questions you may have regarding a medical condition or treatment.